We're going to get started in 2 minutes. Let's get it. Let's go. I like this little motivational clip right here. Get you pumped. Y'all ready? Is y'all's minds clear? Did you take your deep breaths? Did you put your hands flat on the table? And did you take your 4 deep breaths in your nose, smell the roses, and blow out the flowers? All right, Mahogany, welcome in, because we about to do this. We literally about to do this Peds and maternity, okay? That's what we're about to do. And y'all are going to pass that NCLEX, baby. I know you are, because I'm going to be so proud of you all. We got a couple minutes, y'all. 4:40, bright light, welcome in. Court, thank you for liking the live. Everybody go get your material for this class, okay? I think we're going to start playing music at the beginning of the class while we wait on everybody. What y'all think? Y'all like this? Lynn, thank you for liking the live. Hermione, your sister broke out of baby jail. I'm on live. She cannot get on the video, y'all. Sorry. The toddler broke the phase, y'all. Get your sister. I cannot get off the live, okay? What do you need? Tell me what you need.
To help me.
Help you do what? If she made a mess, I'll clean it up. Go get the baby. You get her. I'll clean up the mess, okay, when I get done. All right, y'all. Sorry. The toddler made a mess. Carmani, you need to go get her. She's by the front door, please. I'll clean the mess up. All right, y'all, here we go. It'll be over in just a second, y'all. Just a second. Carmani, please go where your sister is. Urgently. Like now, please, and thank you. All right, guys, take out your handbook. Here we go. All right. So the teal box is the stage. Just so y'all know, I color code things for a reason, so don't overlook that. The gold box, I got tips for y'all. And the red box is critical alerts. So I can't remember if I put it in yours or not. But anyway, if we did not, I will let you know. Why OB is different on the NCLEX. Montana, go upstairs and get your tablet, okay? Okay, go upstairs and get your cookies. Carmen's going to give you a cookie. Go on. Go give her a cookie. They're in the closet. All right. What? I'll wash your shoes. Go. I'm online. All right.
Couldn't get out in the rain.
No. Before we start, I need y'all to understand something fundamental about OB, okay? And nursing on the NCLEX. In every other clinical area, you have one patient, okay? This is where you have one. In OB, you have 2. You have the patient, and I know you may have more than one patient, but what I'm getting at is that in that room, you usually have one patient. Even if you have 5 rooms, you have one patient. In OB, you've got mama and baby. So you got 2 for 1, okay? Christine, welcome in. You got 2 for 1, the mother and the baby. The NCLEX will test you whether you know how to prioritize between the both of them, okay? And that's where people get caught up, all right? Most of the time, you prioritize the mom because a dead mother means a dead baby. But sometimes with like cord prolapse and things like that, the baby's life is an immediate priority and you need to know when is which. I'm going to tell you guys that I delivered a baby in school, in LPN school, kind of, sort of. I was doing the check, right? Even though LPNs don't usually work there in that area, I went to check and mama had a prolapse cord and I had to ride the gurney to the OR. I was like, oh my mercy. And guess what? The baby came out in my hand. It was crazy. Thankfully, the baby made it, but I will tell you that I cried because it was like I had a baby. But anyway, I just thought that was fun to share that with you guys. So OB is also different on the NCLEX because they love to test your knowledge of what is normal versus abnormal. A lot of students panic on OB questions because everything sounds so scary. Hello, Kale. Kale, hello. Thank you for coming in, honey. Your job today is to learn the patterns, the signs that tell you this is an emergency versus this is expected and normal. So let's get into it, okay? 2 patients, you got to think, okay? I want y'all to get that set in early. You got 2 patients, period, point blank, all throughout this segment. So we're going to talk about antepartum first, okay? The high-risk conditions of antepartum. We've got preeclampsia and eclampsia and HELLP syndrome, HELLP syndrome, okay? So antepartum, before delivery. The number 1 most tested OB condition on the NCLEX is preeclampsia. Not gestational diabetes, even though I had them with all my pregnancies. not placenta previa, preeclampsia. So let's make sure you understand it cold. Now, you guys remember we talked about magnesium, right? Yep, and all this grows together. What?
There's one left.
Give it to her.
She already has one.
Okay, give her the other one. I'm online.
What one is it?
Go upstairs and don't come back downstairs. You cannot interrupt my class. It's rude. Sorry. I'm so sorry. If y'all got kids, y'all understand, okay? And I'm going to work. I work night shift, so this is when they see me for a few minutes. So I was like, no. All right. So, preeclampsia is what, guys? Drop it in the chat. What is preeclampsia? And you don't have to go into the big etiology and patho. I want to just know, what is it? What is the main sign? What is it? High blood pressure. That's right. Hypertension. Blood pressure 140/90 or higher that develops after 20 weeks of pregnancy, combined with protein in the urine, okay? Or also known as proteinuria. Thank you, Crit. Okay. That's what I'm talking about. Okay. So that's the definition. But here's what the NCLEX really wants you to know. The symptoms that tell you this is getting serious. Severe headache that doesn't go away. Visual disturbances. Seeing spots, blurry vision, right upper quadrant, epigastric pain, okay? That's the liver being affected. And sudden severe edema. When you see those symptoms, you are no longer dealing with mild preeclampsia. You are dealing with a patient who is heading toward a seizure, okay? Your patient is getting ready to have a seizure. And all of those symptoms that I just told you, it shouldn't be a surprise that those are like telltale, hello, alert signs. Nish, thank you for coming in. You understand what I'm saying? Because none of those say that we are stable or normal, right? Remember that the NCLEX is a safety exam. So is it stable? Is it a chronic or acute situation? Is it stable or unstable? Is it expected or unexpected? Okay? So none of those things, seeing spots, blurry vision that all comes out of nowhere, acute onset of pain, none of that is okay. It's something that we have to look at and prioritize, okay? All right, so your patient is heading for a seizure, okay? A seizure. The treatment for preeclampsia is what? Drop it in the chat because I just spoke about it. It's an electrolyte that we talked about, okay? It's not an electrolyte, but the first word is an electrolyte. Y'all know what I mean, okay? So what do we give? And then we got to check that magnesium sulfate. That's right. And we got to check what? Lynn, what do we have to check before we give mag? The DTR. What does DTR stand for? What does DTR stand for? Okay? Always, always, always. So we want to check the mag level, the deep tendon reflexes. Remember that? Is it? Thank you. All this is starting to come together, right? Exactly. It is starting to come together. All right. So, mag sulfate. So we talked about this in the electrolyte class, but let me reinforce it here. Magnesium sulfate is given to prevent seizures, period, point blank, end of discussion. It's also a tocolytic. It slows or stops preterm labor. Magnesium is a tocolytic. It slows or stops preterm labor. The antidote. What is the antidote, y'all? We talked about the antidote. It's the antidote for almost everything. What is it? What is CG, y'all? Drop it in the chat. CG. Give me that antidote. Give me the antidote. The antidote is CG. Come on, y'all. Make me proud. Make me proud. We talked, it's like calcium gluconate, Chris. You got filtered. Quadrille, thank you. Guys, if you haven't got your daily heart meet, get your daily heart meet. Tap the screen. Get us up to at least 10K. I'll take 25K. Likes, share us out. Y'all hold on my forehead and share me out to 10 people. Share our room out, God. This is y'all's room. I'm just creating the space, y'all. Okay? This is y'all's room. This is our community. I'm creating the space. That's it. Okay? So share us out and get us known on this platform because we are important and we're going to be a powerhouse. All right, so calcium gluconate is our friend in almost every situation, right? Before every dose, you check 3 things. I just told you we're going to check what? To see if the deep tendon reflex is present. Is the respiratory rate above what? What is our magic number for mag? Above what number? Drop it in the chat. DTR, respiratory rate above above 12, right? Respiratory rate above 12. Thank you, Lynn. And we're also going to check to see if they have, yes, I have to work. We're also going to see if their urine is what, 30 mLs per hour if their urine output, correct? Right. So 30 milliliters per hour urine output, their deep tendon reflexes is intact, and their respiratory rate has to be above 12 for the NCLEX purposes, guys. The numbers and stuff that I teach you guys, it comes straight from what the NCLEX requires, okay? Not what is required at my job. It does vary from place to place. This is strictly based on what the NCLEX wants, okay? All right, so respiratory rate above 12. If any of those are abnormal, you need to hold the magnesium and call the doctor, okay? So we talked about the antidote. That's calcium gluconate. You are going to hear me repeat things over and over again. I highly suggest that you pay attention to the things I repeat. Calcium gluconate is the antidote for mag sulfate toxicity. Write it down, circle it, take a picture. I don't know what you want to do with it, but you better remember it. Eclampsia, now eclampsia is preeclampsia plus seizures. If your patient seizes, your priority is the what? In any seizure, what is the priority? I'm going to give you a hint. It's got to do with ABGs. What is your priority when a patient seizes? Drop it in the chat, guys. ABCs, 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 ABCs. Airway. That's exactly right. And it does have to do with safety, Lynn. Airway, breathing, and circulation. In any patient that seizes, I don't care if they're pregnant or not, the airway is always going to be the priority, okay? Turn the patient on their lateral left side, right? And we want to make sure that they're not going to aspirate if they throw up and all that stuff. That also keeps the uterus off the vena cava to improve the blood supply to the baby. Okay? When they're left lateral, it also takes the uterus off the vena cava so that the blood can still flow to the uterus correct, that the baby's still getting blood flow. I got tied up. You should time it, Lynn. That is very important that you know how long the seizure lasts. Okay? So, give oxygen. I don't care what their oxygen saturation is. Give oxygen. Do not try to put anything in their mouth. Call for help. Do not leave your patient. You never leave your patient. The provider needs to know immediately. Never leave your patient. All right? Left lateral, airway, oxygen, call for help. Protect the airway. All right? We're going to move right along. HELLP syndrome, also HELLP. HELLP syndrome is the most severe form. Okay? It's hemolysis, elevated liver enzymes, low platelets. That's what HELP stands for. Hemolysis, elevated liver enzymes, and low platelets. The patient has right upper quadrant pain, nausea and vomiting and malaise. She might even look like she has the flu. The danger is DIC, right? Disseminated intravascular coagulation and hemorrhage, all right? The only cure for HELLP syndrome, does anybody know it? The one and only cure, and it is not a medication. Do you all know what has to happen if somebody is in this exacerbation phase? We got to get the baby out. Delivery. That's it, and that's all. You have to get the baby out. That's the only thing that can save mama and baby's life. Okay? So, if you see HELLP on the NCLEX, the answer is almost always prepare for delivery. Okay? HELLP, prepare for delivery. Do you understand that? Are you following me? Any questions? Delivery is the only cure. It's a life-threatening emergency, guys. The NCLEX will ask you about the priority action is preparing for delivery and monitoring for DIC and hemorrhage. Okay? And time is of the essence. Guys, I told you all, I'm teaching you how to pass the NCLEX, but I also want to teach you how to be good nurses, great nurses. Had my daughter been diagnosed sooner, our outcome may have been different, right? I told you guys that. Don't sit at the desk. If you're working critical care, labor and delivery, I don't care where you're at. I know everybody wants to get on their phone and get all off in a TikTok video and be distracted. Guys, you have to pay attention to those monitors. You have to pay attention to your patient. Do you know how much I'm in the room with my patients? I spend a tremendous amount of my shift at the bedside. right? Because I'm in critical care. My patients are sick. I can't see what's going on with my patient, my actual patient from outside the room while I'm looking at a TikTok video. Okay? You have to be a clear mind no matter what's going on at home. Go to work with a clear mind and just know that mama and baby, their life depend on your skills. And that is a big responsibility. Okay? I told you all I'm very passionate about this profession. And I'm sure all of you get it by now. Okay? So, HELP syndrome, delivery is the only cure. It's a life-threatening emergency, and we're going to prepare for delivery and monitor for DIC and hemorrhage. Now, let's talk about bleeding in pregnancy. There's two big ones you need to know: placenta previa and abrupto placentae. These are tested constantly, and students mix them up, and here's how I want you to remember them. Guys, these are always on the test, and people mix them up all the time. All right? Previa, painless. Previa is painless. Abrupto is agony. Okay? That's easy to remember, right? Previa is painless. And it's bright red, but painless. Abrupto is agony. Dark red, rigorous uterus. Okay? Agony. Dark, dirty, ugly, scary. Agony. Abrupto. Okay? One in the chat if you're with me. Y'all got to communicate with me now. Keep on tapping the screen. Share us out. Do all the things, y'all. Come on now. Let's go. Y'all got to communicate. Get in that chat and talk to me. Are y'all following me? I know you are, baby. Thank you. Y'all follow me? Previa, bright red, and painless. All right? Thank you, Chris. Previa is bright red, painless. Abrupto is deep, dark, agony, angry. Okay? Pain, rigorous uterus, dark blood. Okay? So remember it that way. That's how I remember it. Placenta previa is where the placenta is covering the cervical opening. When the cervix starts to dilate or efface, the placenta bleeds. The bleeding is painless and bright red. There is no pain. The uterus is soft. And here's the most important nursing action. Do not perform a vaginal exam. If you put your fingers in there and touch that placenta, you can cause a catastrophic hemorrhage. You can kill mom and baby. Do not put your fingers in there. Okay? Do not. All right? This is a classic NCLEX. Which action is unsafe question? The answer is performing a vaginal exam on a patient with placenta previa. That will be on your NCLEX. You can guarantee it. Don't put your fingers in there. You're going to kill your mom and your baby. Okay? I know I'm blunt and I say the K-I-L-L word a lot, but I'm saying it because that's what will happen. All right? All right. Now, abrupto placentae, deep, dark, rigorous uterus, angry. Right? Abrupto. Right? It's the opposite. The placenta is in the right place, but it's separating from the uterine wall. The bleeding is painful. It's dark red. And the uterus is like a board. Okay? It's rigid and it's tender. This is also a medical emergency because the baby is losing oxygen supply. A lot of times this is missed and babies will end up with like cerebral palsy and things of that nature from lack of oxygen, a birth injury. Okay? The risk factors are hypertension, cocaine use. People still use cocaine while they're pregnant, unfortunately. Trauma, cigarette smoking, okay? Things like that. You want to monitor for fetal distress and prepare for an emergency delivery. Okay? Got it? So previa is painless. Abruption is agony. All right? Thank you for that repost, Hayne. Y'all, I see people in here that I don't see up in my bubble. Y'all go get y'all's daily heart me right there at the top. Y'all see my name, Shay RN, that orange heart? Click on that. It's one coin, 1 penny. Just so y'all can check in and tell TikTok y'all love Coach Shay. Everybody put I love Coach Shay in the chat. Y'all gonna make my day. I wore my pretty red country girl dress for y'all today, so I look like I'm in the kitchen baking. I love this dress. Y'all got it at Walmart, by the way, and I love it. All right, welcome in, Sky. Sky Gabe, welcome in. All right. Let's see where we're going here. Jackie, welcome in. So 2 more antepartum conditions. Quick but high yield, okay? Ectopic pregnancy is, you're welcome, babe. The fertilized, thank you, Lynn, for that heart me, boo. Ectopic pregnancy is the fertilized egg and implants outside the uterus, right? Usually in a fallopian tube. Barbara, welcome in. Sharp unilateral pelvic pain is a symptom. And you also get a positive pregnancy test, right? Because those HCG levels in your body. There's no intrauterine pregnancy on an ultrasound. This is a surgical emergency, guys. Cash money. Chris sent her first. Thank you for that rose. Oh, thank you. Thank you. Thank you. I appreciate you. So this is a surgical emergency. Okay. It's very unfortunate. And a lot of times mamas, all the time, they struggle almost all the time with this, right? Because they're pregnant, but it's not in the uterus, and they have to abort the pregnancy, even though it's not where it needs to be, right? So in a mama's mind, they've been pregnant since they saw those blue lines on the test. It's hard. You have to be an emotional support for them as well. This is a very hard time. Trust me, from a mama that had a micropreemie and I went through a month of agony, it is so hard. You got to love on your mama, okay? So sharp unilateral pelvic pain, positive pregnancy test, no intrauterine pregnancy on the ultrasound. Surgical emergency. The tube can rupture and cause hemorrhagic stroke. That's why it is an emergency. All right. The molar pregnancy, right? It's an abnormal trophoblastic tissue. So there's no viable fetus. All right. The clues: the uterus is larger than expected for dates. All right. Markedly elevated HCG. Preeclampsia before 20 weeks, which should never happen. And no fetal heart tones. Right? It's a molar pregnancy. It's a false pregnancy. But you're getting these symptoms. The ultrasound shows a grape, like grapes in your uterus versus the fetus. All right. The treatment is a DIC, right? Or DNC. I said DIC. DNC. They're going to do suction and cartilage. Okay. HCG must be monitored for 1 year because it can become malignant. So after a molar pregnancy, HCG has to be monitored for 1 year. Okay. So molar pregnancy is preeclampsia before 20 weeks. That should never happen. That's a key. All right. That's a red flag. Normal preeclampsia does not occur before 20 weeks. If you see early preeclampsia plus no fetal heart tones on the NCLEX, that is a molar pregnancy. All right. It's one of the most missed OB questions on the NCLEX. Intrapartum. All right. Fetal heart rate patterns and labor complications. All of this is the most missed stuff on the NCLEX. That's what I keyed in on so we could focus, okay? All right. During labor, the most tested intrapartum topic on the NCLEX is fetal heart rate interpretation. You need to know the 5 patterns. All right? Normal baseline is 110 to 160. Anything outside of 110 to 160, you need to do something about it. These are little babies. Okay? They're little babies. They're little people. Little people, we think a lot of times they can take more than we can. However, there's some things that they can't. Okay? All right. Early decels. Early decels. The fetal heart rate dips down during a contraction and comes right back up when the contraction ends. So basically, mom is having a contraction, so baby is under pressure and they go into distress, right? It mirrors the contraction. The cause is usually head compression as the baby moves through the pelvis, all right? This is normal and reassuring, and no action is needed. All right? The NCLEX will try to trick you into thinking early decels are dangerous. They're not. Early decels, the baby has that decel, and then after the contraction's over, they go right back up. Okay? So even though when they were stressed out, right, they reacted because that's what we do. We're humans. But after it, the baby pops right back to where they need to be. If the baby didn't go back up to normal, then we would have a problem, right? Because they got stressed out and now they're not recovering correctly. So then you have variable decels, all right? Variable decelerations. Guys, this will be linked in my bio so you all can go watch it later too. All right, variable decels. Abrupt drop in the fetal heart rate that looks like a V or a W shape. So variable decels, right? Thank you for that follow. Variable decels, V or W shape, right? Variable, here's two V's for a W, and then V for the V shape, right? Remember it like that. Variable decels, abrupt drops in the fetal heart rate that look like a V or a W. They can happen at any time, before, during, or after a contraction. The cause is umbilical cord compression. The action, reposition your patient. It's that simple. What can you do right now? Reposition your patient. If you move the patient, the baby is going to move. All right, left lateral first. Why? Because that helps the baby keep getting oxygen. If that don't work, try the knee to chest position and give oxygen and IV fluids and notify the doctor. All right, you want to communicate with the doctor, but you always want to do what you can do first. The NCLEX loves that. Okay, late decels. This is the one that should make you move fast, right? The fetal heart rate drops after the peak of the contraction, right? Which means the baby is the contraction's letting up and the baby's heart rate is still dropping, okay? It starts late and returns late. The cause is a uroplacenta insufficiency, right? The placenta is not delivering enough oxygen to the baby. This is the most concerning fetal heart rate pattern on the NCLEX, and here's the priority order to memorize this, okay? 1, stop Pitocin. 2, left lateral, all right? 3, oxygen, 8 to 10 liters, okay? 4, IV bolus. 5, notify your provider. Y'all got it? Stop the Pitocin. Reposition them left lateral. Give 8 to 10 liters of oxygen. IV fluid bolus and notify the doctor. All right? If Pitocin is running, and the reason I said stop Pitocin, if Pitocin is running, it is causing the uterus to contract too hard, cutting the blood flow off to the placenta, okay? So you stop it first because we want to stop that contraction, okay? 2, the left lateral position. 3, oxygen 8 to 10 liters, right, per minute via like the face mask. The IV fluid bolus and then notify the doctor. The NCLEX will ask you which action is first. The answer is stop the Pitocin. I'm giving you those back to back because they want to know what you do first. So whatever the root cause of the problem is, which is the strong contraction, you want to intercept that, right? So we're going to stop the Pitocin to stop that heavy contraction. The reason I'm mentioning Pitocin is because that is likely to be your question on the NCLEX. It's going to talk about Pitocin. Okay, Pitocin makes contractions stronger than what they would normally be. All right. This is a critical point. Late decels, stop Pitocin first. Okay. Late decels, stop Pitocin first. This is the most missed intrapartum priority question on the NCLEX. Student want to always call the doctor. Wrong. Why? Because while you're calling the doctor, the medication can be stopped. And to be in all actuality, once you get experience, guess what? You're going to be doing all this at the same time. You're going to be have the doctor on speed dial, because that's what I would do. Got the doctor on speed dial. I'm pushing the button. I'm pushing mama's hind end over. Like I'm doing 4 or 5 things at one time. On the NCLEX, you can't do that. You can only do one at a time. So you're going to stop Pitocin first. Okay? Now, we got cord prolapse. This is a true emergency. This is what I was just talking about, y'all. The umbilical cord slips through the cervix before the baby's head. Every contraction compresses the cord and cuts off the baby's oxygen supply. This is why if you check somebody's cervix and you feel if they got the cord prolapse, you don't move your hand. You leave your hand there. This was on my NCLEX. I remember it. you leave your hand there and you ride that gurney to the OR. You cannot move. You better get comfortable if you can. Okay? The umbilical cord slips through the cervix before the baby's head. Every contraction compresses the cord and cuts off the baby's oxygen. Signs of sudden, severe, variable, or prolonged decels after the rupture of membranes or the water breaks. You might see or feel the cord in the vaginal opening. Got it? If you do, you got your hand there, don't move it. Be still and holler for help. So, here's what you do. And the order is what matters, okay? You call for help. Then, this is a key action, okay? You put your hand in and manually elevate the presenting part of the cord. Your hand goes in and it does not come out until that baby is delivered via C-section. Do you got it? Do you got it? Everybody got it? We got it? One in the chat if you got it. Because if you move your hand, if you don't do this right, that baby is going to pass away or have some type of brain injury. All right? We got it? You position the patient in a knee, chest, or Trendelenburg, thank you, Keisha, position. You give them oxygen. If the cord is exposed, you wrap it in a warm saline-soaked gauze. Do not push the cord back in the uterus. Emergency C-section. Let's get prepared because that's what's going to happen. So, this is the NCLEX tip. The cord prolapse question is often framed as the nurse feels the umbilical cord at the vaginal opening. What is the priority action? The action is manual elevation of the presenting part, not calling the doctor and not repositioning it alone. Okay? The answer is manual elevation of the presenting part. Got it? Thank you, Lynn. Thank you, boo-boo. Okay? All right, one more intrapartum topic. Pitocin. Normal contractions last 60 to 90 seconds and they occur every 2 to 3 minutes. Okay? The uterus relaxes completely between contractions. Uterine hyperstimulation is when contractions are longer than 90 seconds, closer than 2 minutes apart, or the uterus never fully relaxes. Okay? This cuts off the blood flow to the placenta. Action. What do you think you do in this situation? The Pitocin is causing it, right? Stop the Pitocin. Stop it. Okay? One in the chat if you got it. One in the chat. Everybody has hashtag NCLEX. Hashtag NCLEX. We want to tell TikTok to send us people that are interested in NCLEX. So put a hashtag and NCLEX in the chat. Thank you. All right. Postpartum PPH assessment and infections. All right. Postpartum hemorrhage. That's what PPH stands for. Thank you all. Lynn, Keisha, Chris, thank you, thank you, thank you. All right, PPH stands for postpartum hemorrhage. More than 500 mLs of vaginal bleeding for a vaginal delivery with a C-section greater than 1,000 mLs. That is noted as a postpartum hemorrhage, okay? All right, y'all remember the word boggy, B-O-G-G-Y, boggy uterus? Postpartum hemorrhage. It's defined as blood loss greater than 500 mLs after a vaginal delivery or greater than 1,000 after a C-section, okay? The number one cause, 80% of the cases, is uterine atony, okay? Right? That's our boggy uterus. The uterus is not contracting. It's boggy, right? Soft, squishy, all the things, right? When you feel a boggy uterus, what is your first action? Y'all should know this if you don't know nothing else. What should you do if the uterus is boggy? It hurts like a mama jama. What should you do? Massage the fundus, Chris. It filtered your comment, but I can see it. Here, that's ridiculous. I gotta approve it. Y'all, eventually I'm gonna make y'all moderators so y'all can help me with this stuff because I can't teach and do all the stuff. That's crazy. Your calcium gluconate got filtered out too. I don't know why TikTok does that. All right. You're going to massage the fundus. The fundus among us. You're going to massage it. Thank you, boo-boo. I know, right? The uterus is not contracting. It's boggy, soft, and squishy. So when you feel a boggy, soft, squishy uterus, you're going to massage it. Thank you, Keisha. And that will help that uterus start to contract and get rid of all that gunk, okay? So you don't give medications first. Why? You got to go get the medicine. What can you do right now as a nursing intervention? You're going to massage it, okay? Boggy massage. Hemorrhage, if the patient's hemorrhaging, massage it, all right? Remember the 4 T's that cause, for the causes of postpartum hemorrhage, okay? Tone is the uterine atony. Trauma is like lacerations, right? Tissue, the tissue retained placenta or a thrombin. You did have a test. I know you did. Chris said I had a test question like that. I know you did. That's why I pulled this stuff and put it on here. Listen, that comprehensive review that you got, I have got so much material that I've used along the way. Okay, I used to teach clinicals also. The questions that I decided to break down for you guys and explain in my comprehensive review is literally the most missed questions on the NCLEX. That's what my comprehensive review is. For all of you all that do not know, I highly suggest you go to the link in my bio and get it, because it is very much worth how much it is. And thank you all for getting me to 10.4K taps. Keep tapping. Keep a tapping. Keep a tapping at you can't come in. Keep a tapping at you can't come in. Okay. But I highly recommend it because it's worth that and a whole lot more, especially with me teaching you. Okay. Lady J liking that live. Thank you, boo. Lynn is liking that live. All right.